renal and CV event in diabetes management, and the speaker is Dr. Rajiv Kovil. I invite Dr. Rajiv Kovil. Rajiv Kovil is Medical Director and Consultant Diabetologist, Dr. Kovil's Diabetes Care Center, Mumbai. He is a consultant in Nanavati Hospital, SL Raheja, Arogyandhi and BSES Hospital. Also, he is an invited faculty at JPEF Medical College. He is a faculty of numerous international and national seminars. He is founder member of United Diabetes Forum. He is faculty for teaching diploma diabetology students, principal investigator for many clinical trials, multiple articles in international and national journals. He is a gold medalist in diabetology at Mumbai University. Over to Rajiv.
Thank you, Dr. Shaji. Thank you, the whole organizing team, for having me here. I'm just going to present few principles that we do, and we always have spoken about Mace, as in major adverse cardiovascular events, and whether we should add renal to it, because a lot of our patients are also having renal events, and there is a complete a conglomeration where cardiovascular and renal events occur together in people with type 2 diabetes. So we all know how many diabetics we have, but importantly, the risk of chronic kidney disease is very, very high, and majority of them have some form of cardiovascular or renal complications. And 4 out of 5 people with type 2 diabetes would die of cardiovascular or a renal cause. This is Dr. Rajput's study, which said that we have almost 50% of our patients with type 2 diabetes have some form of chronic kidney disease. But if you look at the overall papers from India, it's anywhere between 30 to 40% of our people with type 2 diabetes have some form of chronic kidney disease. It could be albuminuria, it could be EGFR. So there's an intertwined relationship between chronic kidney disease and cardiovascular disease. If I take you back to UKPDS, UKPDS had a post-hoc analysis which spoke about the progression of people in diabetic kidney disease or chronic kidney disease. It was called chronic kidney disease then. And UKPDS was done in newly diagnosed people with diabetes. And what it showed is that at every stage of chronic kidney disease, the patient was at higher risk for a cardiovascular event than progressed to the next form of chronic kidney disease. That means at any stage, the patient is at very high risk for a cardiovascular event. And that's the time when talk started that probably CKD is also CHD risk equivalent, as in the 90s we had talked that all diabetes is also CHD risk equivalent. So what we are seeing here is that whether we should do a primary prevention or we should do a secondary prevention, because the gun is already loaded with all the risk factors, whether it's lipid, blood pressure, weight, glucose, hyperglycemia, and if we do this primary prevention, we can actually put a lot of people like nephrologists and cardiologists out of work. So this is the natural history of type 2 diabetic kidney disease. You have functional changes, structural changes. The first stage you may pick up is a urine albumin creatinine ratio, a mild proteinuria progressing to macroalbuminuria, then the GFR falls down and patient progresses to an end-stage renal disease. Way back, we have already known that glycemic control can help in microvascular complications. That's what the UKPDS told us, that's what the advanced told us, that was the steno, which was multifactorial, told us. And again, this paper told us that we could reduce the risk of progression of macroalbuminuria by 56% by targeting to a goal of less than 6%. Here, that's why there needs to be a paradigm shift from Mace to Marce, and we need to also take care of this renal events. It's important that whenever we intervene for reducing the progression of chronic kidney disease, we not only prevent the progression of kidney disease, but we also prevent a lot of cardiovascular events. And today I'm going to speak about a molecule. I'm contracted for this as a speaker for this particular molecule, that there's a combination of dapagliflozin and gliclazide available in the market as a fixed drug combination. A lot of people will say that it's quite irrational. Why would we combine an SU plus a dapagliflozin? So the genesis of this combination comes from a Chinese study which said that if you are able to add an SGLT2 to an existing SU and especially gliclazide, one, the overall glycemic control gets better. The the primary failure is after 28 months, and all the other factors like the ACR and everything, there's a synergic action. Now this is a phase 3 clinical study of this fixed drug combination of DAPA and glyclazide. We are comparing a combination of DAPA glyclazide as a fixed dose versus glyclazide single tablet. So we know that the HbA1c would be better, but here we are looking at how the pharmacokinetics and pharmacodynamics, and by combining this particular drug, are we causing any harm? So one, the HbA1c was better, which is two drugs versus one. Obviously the HbA1c is better. The postprandial was also better, but majority of our patients did reach the target glucose of less than 8%, where the HbA1c was much higher. So the phase 4 study which was done for the DCGI clearly suggests that this drug can be used. And what do our guidelines say? That glyclazide is the SU of choice up to a GFR of 30, especially because its metabolites are not active as compared to glimepiride, where you have active metabolites and the chances of hypoglycemia go up. Dapagliflozin, we know that with the robustness of evidence which the DAPA CKD has given us, that it is very well, it dilates the efferent, and that's why it reduces the intraglomerular pressure, that's how it reduces the proteinuria, and also improves the tubuloglomulular ischemia which occurs because of hyperfiltration. So overall, a combination of glyclazide and dapagliflozin can be used where it's convenient. I wouldn't say it is the drug of choice. Where it's convenient, where we need to use an SU for good control, because the renal protection of SGLT2 we know, whether it's a hemodynamic, the osmotic diuresis, the reduction in glomerular hyperfiltration, the hyperuricemia, the reduction in uric acid, the weight of blood pressure, we don't know, but overall there is a benefit on renal protection with this. Glyclazide, we are under users of glyclazide for reasons unknown. Glyclazide has been a molecule which has been there for much earlier than the other molecules which come in. It has got some action on the oxidative stress. A head-on study versus glimepiride clearly showed that was the guide study 2006, clearly showed that the hypoglycemia is much lower with glyclazide as compared to glimepiride, and there seems to be some amount of protection to the kidney. This particular study 8 years back, there was a Chinese study showed that there was good nephroprotection versus glimepiride along with better glucose control patients with preserved renal function. Steno-2 we know is a landmark study. We know that 21 years after Steno-2 we are still harping the benefits of Steno-2. Steno-2 was a multifactorial intervention study using a glyclazide-based regimen. It was not purely a glyclazide-based study. Then we had the advance, which was also a glyclazide-based regimen and showed a sustained nephroprotection action even after 10 years of intensive treatment, leading to a 12% reduction in cardiovascular complications. DAPA-CKD was one of the landmark studies, importantly landmark because 2/3 of the patients were diabetics, 1/3 did not have diabetes. Till that time the eGFR cutoff was 30 for SGLT2. Here they tested between 25 to 75. We had 15% of patients who were below an eGFR of 30. If you look at the primary endpoint, 30% reduction in a 50% reduction in eGFR, end-stage renal disease, cardiovascular or renal death. If you only specifically look at the renal endpoints of DAPA-CKD, there was a 44% reduction in the renal endpoints in the DAPA-CKD. So the DAPA-CKD clearly established the superiority of dapagliflozin in preventing progression of diabetic and non-diabetic kidney disease and also treating chronic kidney disease. Again, there was a 29% change in the UACR. So there's a lot of nephroprotective action even in the declared TB, which again had almost 2/3 patients with established 1/3 patient with established cardiovascular disease and 2/3 with multiple risk factors, the garden variety BC. Again, the post-hoc analysis had shown that the lower risk of kidney mortality or end-stage renal disease as well as reduced risk of a sustained decline in eGFR. So, mine was a very short talk. So, my take home is that we have a fixed drug combination of glyclazide plus dapagliflozin, where you feel that the pill burden is high, where you feel that the patient will require SU to control his blood sugar. Many of our patients do require SU even at an eGFR of 30. Consider this combination, because separately given, the patients usually the adherence is very poor. CKD is increasing annually, and diabetic kidney disease results from a lot of reasons where hyperglycemia causes the traction, but pathological and structural change is dominated. So early combination therapy, especially with glycoside and dapagliflozin, could focus on major adverse renal and cardiovascular events, and we could have HbA1c coming down to less than 7 and less than 7 using this combination. And among SUs, glycoside is preferred in chronic kidney disease purely because the metabolites are not active, hypoglycemia is lesser. That's why the KDIGO clearly recommends when you need to use an SU, consider glycoside. Thank you all for your patience.